Good morning. Thank you so much, Chairperson, for the kind words of introduction. And also, I'm extremely grateful to G. Vijayakumar sir and team for having me here in this August audience. So, in the next 10 or 13 minutes, I will be speaking about a molecule known as IGLAR-LIXI, a solid approach to break treatment complexity. And I've been contacted by Sanofi for this talk. So Indian type 2 diabetes mellitus, India's type 2 diabetes mellitus burden remains high and continue to rise. There is no doubt. India is becoming the global diabetic capital. There are around 6.9 crore people with diabetes mellitus in India, and the proportion is increasing. Around 52% of the people are undiagnosed with the diabetes mellitus. And there are so many unmet needs in advancing diabetes management. We know that patients don't achieve targets. And if the patient is on a particular insulin regimen, there are difficulties in advancing the insulin regimens or optimizing or intensifying the insulin treatment. So if the patient is already on a basal insulin, how to optimize the treatment or how to intensify the treatment, there are different options. One of the options is making it a basal plus regimen or making it a basal bolus regimen. Again, the number of injections will go up, and there is a chance of hypoglycemia as well as chance of weight gain is also there. Another option is a simple regimen that many of us will be following, like switch to a premixed insulin from a basal insulin so that they can intensify with the same insulin. And again, the chance of hypoglycemia and weight gain is there. And another attractive option, which everybody will be resolving nowadays, is GLP-1 receptor agonist, because it has got similar efficacy to other advancement options. But the problems again comes with the gastrointestinal side effects, and you may require further injections. And one of the very attractive options include a fixed ratio combination of a GLP-1 receptor agonist as well as a basal insulin, which can tackle multiple defects in the pathophysiology of diabetes mellitus. It can reduce the total daily insulin dose, and it can prevent the weight regain or weight gain associated with insulin therapy, and the titration might be easier, and it is a once daily administration. So this combination of a once daily fixed combination of insulin plus a GLP-1 receptor agonist is an attractive concept for glycemic control at the same time without increasing the risk of hypoglycemia and without producing much weight gain or even mild weight loss you can expect because of the presence of GLP-1 receptor agonist. So if you have a combination of a basal insulin plus a GLP-1 receptor agonist, you can tackle multiple physiology defects. We have talked so many times about the ominous octet of the pathophysiology of diabetes mellitus. At least 7 out of these 8 defects can be tackled by this combination of a GLP-1 receptor agonist as well as a basal insulin combination. There is increased convenience, therefore improved adherence to therapy, earlier achievement of glycemic control, and potential reduction risk of side effects. And potential to delay underlying disease complications can also be expected with the use of this sort of a dual combination. And if you combine these basal insulin with GLP-1 receptor agonist, they have got a complementary mode of action. What does basal insulin do? Any comments? Basal insulin predominantly suppresses the hepatic glucose output so that the fasting glucose comes down. The result is fasting blood glucose is on target. What does short-acting GLP-1 receptor agonist do? It will reduce the PP sugars. Glucose-dependent insulin release will be coming down with the use of GLP-1 receptor agonist, and there is decreasing glucagon secretion and delayed gastric emptying, and the PP sugars also will come down. So with the use of a fixed combination of a GLP-1 receptor agonist as well as a basal insulin, you are controlling both fasting glucose as well as postprandial glucose, and you are achieving a wholesome glycemic control with significant reduction in the HbA1c reduction on long term. So here you are having a molecule which has got the combination of a conventional, whatever we have been doing for a long period of time, giving insulin for a patient whose sugars are not controlled. That insulin is there, and we are combining a newer drug class, that is GLP-1 receptor agonist, which can tackle the postprandial glycemia without producing weight gain, or some weight loss is there, and the risk of hypoglycemia is also coming down. So this seems to be a very reasonable combination of achieving glycemic targets with added advantage of no hypoglycemia as well as no weight gain. So we have seen this again and again, the ominous octet of pathogens of type 2 diabetes mellitus. There are defects of various organs and various cell lines, In the liver, there is problem. Beta cell depletion is there, beta cell decline is there, alpha cell hyperplasia is there. In the brain, there is action of glucose regulation is there, intestine glucose absorption as well as GLP effect is there, kidney renal glucose reabsorption is there, fat lipolysis is there. So all these defects will be tackled except the renal glucose reabsorption. All the defects will be tackled if you are giving a combination of a basal insulin as well as GLP-1 receptor agonist. So there is a decrease in hepatic glucose output, decrease in glucose uptake in muscles, decrease in lipolysis, as well as increase in the satiety, as well as decreasing gastric emptying by the GLP-1 receptor agonist action. So you are tackling 7 out of 8 defects here if you are giving a combination of a GLP-1 receptor agonist and basal insulin. As per all the guidelines, the ADA 2026 guidelines says that you can always think about this sort of a combination of fixed ratio combination of basal insulin plus GLP-1 receptor agonist can be considered in a patient with diabetes mellitus if the sugars are not fairly controlled for achieving better glycemic control. Even IDF 2025 and ADA 2025 have endorsed the concept of giving a GLP-1 receptor agonist as well as basal insulin co-formulation. So what is the evidence? Is there any evidence to suggest this sort of a combination over and above giving basal insulin or giving co-formulation of insulin, short-acting as well as long-acting insulin analogs, or a co-formulation of ida-gasp? There are 2 studies which have shown that this sort of a combination is superior to giving ida-gasp or a co-formulation of insulin alone. So we are seeing a person here who is 45-year-old gentleman, diabetic for the past 8 years, on metformin, sita as well as dapagliflozin. HbA1c is 8.5, BMI is 25. So you are having an option of starting insulin, whether to start on ida-gasp or iglarlixy. That is the question that is coming in front of us. So what will you start for this patient? As per the evidence from the SOLID-D study, which was a comparison between starting once daily iglarlixy versus once daily ida-gasp in patients, 24-week study with HbA1c between 7.5 to 11, and the study was conducted for 24 weeks. The baseline characteristic was similar between these 2 subgroups: iglarlixy, age, male to female ratio, BMI, duration of diabetes, HbA1c, metformin and background drug usage, and ida-gasp and iglarlixy was compared. And you can see that there is superior reduction in HbA1c from baseline to week 24 with iglarlixy. You can see that around 0.2 to 0.3% greater HbA1c reduction if you are giving iglarlixy when compared to ida-gasp. So if you are starting the patient on iglarlixy for such a patient, you have the added advantage of having a greater HbA1c control because of the presence of 2 class of molecule. In ida-gasp, there is only 1 class of molecule, that is insulin, but again it's a combination of short-acting and long-acting insulin. Here we are having 2 class of molecules. One is a basal insulin and the other one is a GLP-1 receptor agonist. So when you are giving this combination, you can tackle multiple defects and you can have better glycemic control. But at the same time, there is another advantage. There is no weight gain. Actually, there is a small weight loss with this molecule as well. We have been talking about weight, the relevance of weight in the management of diabetes mellitus and how we should lose weight and everything. So here we are having an insulin plus a GLP-1 receptor agonist, but there is weight loss as well. And along with that, you can see that the persons achieving the combined target of 3 targets. That means HbA1c less than 7 with the no weight gain, with the less incidence of hypoglycemia. If you have these 3 aspects together, greater proportion of participants treated with iglarlixy reached HbA1c less than 7 without body weight gain as well as without hypoglycemia risk. So that is a great thing. So here you can see that even the PP sugar control, which will be better. Any comments? If you see the PP glycemic control with this is ida-gasp and this is iglarlixy at the end of the trial, you can see that even the post-breakfast, post-lunch and even sugars and to some extent post-dinner as well as coming down with the use of this molecule. So PP sugars are also significantly coming down in patients who are being put on iglarlixy when compared to ida-gasp. And it is very clear. I think it doesn't require rocket science to see that the insulin dose is less because we are giving a GLP-1 receptor agonist. So the total insulin requirement also is coming down. Subsequent to that, the weight gain also is coming down. So here you are having a better PP glycemic control. Both fasting and better fasting glucose control is similar, but better PP glycemic control is there with when you are giving a combination of iglarlixy. So again, even rate of hypoglycemia and other nocturnal hypoglycemia about which we are worried. So we know that nocturnal hypoglycemia is a real villain. It can lead to cardiac arrhythmias and silent cardiac events at the night. So we are having reduction in the nocturnal hypoglycemia and any type of hypoglycemia if you are using Igdarlixy when compared to Ida-gasp. So the incidence of nocturnal hypoglycemia is significantly less, the hypoglycemia between 12 midnight as well as 6 a.m. if you are giving Igdarlixy when compared to Ida-gasp. So the summary and conclusion of this study, solely this study, is that there is non-inferiority and statistical superiority in HbA1c reduction, superior body weight benefit, more patients achieve the composite outcome of less than HbA1c less than 7, body, no weight gain as well as no hypoglycemia, low risk of hypoglycemic events. So we are going to another scenario here. There is one more study that is known as solely mixed study. We are having a patient who is already on this basal insulin of around 26 units with OADs. Whether to start the patient on once daily Igdarlixy or twice daily premixed insulin analog or bias 30 or no mix, in other words. So the study was conducted for 26 weeks. You can see that Igdarlixy once daily was superior to twice daily premixed insulin analogs as far as HbA1c control is concerned. It was superior as far as weight is concerned, and even the secondary endpoints are coming down significantly. The 3-point, we already told, the HbA1c less than 7 with no hypoglycemia without weight gain again is more, and even the total insulin dose is significantly less if you are using once daily Igdarlixy when compared to twice daily premixed insulin analog, especially for a patient who has already been on basal insulin treatment. So there is significantly lower risk of hypoglycemia as per solely mixed study. Again, ADL level 1 hypoglycemia as well as level 2. You can see the percentage here. ADL level 2 hypoglycemia is around 68% lower when you give Igdarlixy when compared to twice daily premixed insulin analog. So there is a very huge percentage. So hypoglycemia risk is definitely there, as we can expect. And so as per the solely mixed study again, there is better glycemic control with weight benefit, less hypoglycemia, fewer daily injections, and similar proportion of serious adverse events, so that it is again the patient is getting benefited. Again, as per the patient satisfaction scores, you can see that the people who are taking, as an extension of solely mixed study, it was seen that people who are taking Igdarlixy, around 81% people are happy, and bias 30 happiness index is less, the patient satisfaction index is less. So towards the last part of my talk, so how this molecule is prepared. It is a fixed dose combination of 2 units of glargine with 1 microgram of lixisenatide. So you have a pre-filled pen of 300 ml, 3 ml pre-filled pen, 300 units of insulin glargine plus 150 microgram of lixisenatide. The dose range 10 dose steps to 40 dose steps. So the starting dose is 10 dose step. This is what you call. So for a patient who is insulin naive patient on OAD or GLP-1 receptor agonist, you can start with 10 units. And the patients who is already on less than 20 units of glargine, you can start with 10 dose steps. If the person is on more than 20 units of glargine, you can start with 20 dose steps. And the adjustment is again based on the fasting glucose. If it is more than 100 and less than 140, you can increase by 2 units. 80 to 100 continue the same dose. Less than 80, you can reduce by 2 units. It has to be injected before at one meal. Just any time before 1 hour of the meal. I usually give it half an hour before breakfast or before dinner, whatever, once daily. Meal, if you miss 1 dose, you can take it with the next meal. There is another flexibility advantage as well. And elderly, it can be safely used because the chance of hypoglycemia is extremely less. Renal impairment also, if GFR is more than 30, I will take only 1 minute more. 30 seconds more. Pregnancy, it is contraindicated, we should not give. Hepatic impairment also you can safely give. To summarize, Igdarlixy can be given. It's a combination of a basal insulin plus a GLP-1 receptor agonist, which is lixisenatide, which is short-acting GLP-1 receptor agonist. Once daily administration within 1 hour prior to meal. It need not be 1 hour, it can be 30 minutes or 15 minutes within 1 hour prior to meal. And it has got a complementary mode of action of a basal insulin action is there, along with that GLP-1 action is there with the better GI tolerability. Unlike other GLP-1 receptor agonists like SEMA or other drugs, the GI tolerability is better. Effective HbA1c reduction is there. It controls fasting PP as well as HbA1c. Weight benefits there, once-a-day dosing, more people achieving glycemic targets. So 2 trials. Solely D trial indicate that Igdarlixy is simple, well tolerated with better glycemic control, body weight benefit over Ida-gasp. Solely mixed told that efficacious, simpler, well tolerated, provide better glycemic control with weight benefit and less hypoglycemia when compared with twice daily. It is twice daily bias 30. Thank you so much for your patient listening. Thank you.